Welcome to The Explainer. I am absolutely thrilled you're here. If you're tuning in, you're likely the kind of focused learner who wants a direct, no-nonsense look at how things really work. And today, we're zeroing in on a procedure that is incredibly common, yet honestly, widely misunderstood: cataract surgery in the geriatric population. You see, for a 78-year-old patient, this isn't just some simple optical fix, it's a complex medical event. We're going to look closely at the very real physical and pharmacological hurdles that older adults face before ever entering the operating room. But more importantly, we're going to see how modern medicine brilliantly overcomes every single one of them. Okay, let's dive right into this. Am I too frail for cataract surgery? It's a huge question, right? And it's the primary anxiety for so many patients and their families. They wonder, am I too old? Is my body even up for this? And it's a completely valid fear. When you're juggling overlapping conditions like arthritis, diabetes, or cardiovascular issues, the prospect of any surgery can feel completely overwhelming. But today, I'm going to demystify this entire preoperative process for you, because advanced age alone is not a deal breaker, and the specialized clinical pathways we're about to explore will show you exactly why.
So here's our roadmap for today's explainer. First, fasting and prep. Second, the Flomax factor. Third, the blood thinner question. And fourth, overcoming physical challenges. Let's get right to it.
All right, Section 1, Fasting and Prep, Setting the Baseline. Look, before anyone even gets near a surgical microscope, there's a foundational set of preoperative protocols that absolutely have to be followed. This strict fasting timeline is designed to prevent something called pulmonary aspiration. Because patients receive intravenous sedation, that relaxed twilight state, the stomach needs to be entirely empty to keep the airway safe. So, after midnight, no solid foods, no soup, no broth. Now, up to 3 hours prior, you are allowed clear fluids, but pay close attention to what that actually means: water, black coffee, or plain tea. No milk, no cream, no artificial sweeteners. And note that chewing gum, hard candies, and cough drops are strictly forbidden because they stimulate gastric juices. Then, on the morning of the surgery, you take your essential medications with just a tiny sip of water. But that begs the question, which medications?
So, the really crucial point here is this stark contrast in the morning medication rules. You absolutely must take your essential cardiovascular meds, think beta blockers and antihypertensives, to keep your heart stable. But you've got to withhold oral diabetic pills and morning insulin. Why? Well, if you take insulin while in a strict fasting state, your blood sugar could plummet, pushing you into a dangerous state of intraoperative hypoglycemia right there on the surgical table. It's a really delicate balancing act between managing your systemic health and meeting the surgical requirements.
And beyond the meds, the physical prep is just as deliberate. You'll need to wear loose, front-opening clothing. And no, that's not just to keep you comfortable, it's to easily facilitate the attachment of cardiac monitoring equipment to your chest. You also must avoid all facial cosmetics, face creams, and perfumes. This is vital to maintain the absolute sterility of the surgical field right around your eye. And finally, you can't just grab a taxi or hop on the bus home afterward. Because of the lingering effects of the IV sedation, bringing a responsible adult escort to drive you home is a mandatory legal requirement. Moving on to Section 2, the Flomax factor, alpha blockers and the eye. Now, what could a prostate medication possibly have to do with microsurgery on your eye? The biological mechanism here is truly fascinating. Tamsulosin, commonly known as Flomax, is prescribed for enlarged prostates. It works as an alpha-1A adrenergic receptor antagonist. Basically, it targets specific receptors to relax the smooth muscle of the prostate to improve urinary flow. But here is the biological plot twist. The iris dilator muscle in your eye contains those exact same alpha-1A receptors. This anatomical overlap creates a major, totally unexpected challenge for the eye surgeon. When the eye's iris is exposed to this medication, it effectively loses its structural tone. This leads to a perfectly named complication: IFIS, or intraoperative floppy iris syndrome. Imagine the surgeon trying to work through a tiny incision less than 3 millimeters wide. Instead of a nice, stable pupil, the flaccid iris starts to billow like a loose sail in the fluid currents of the eye. It can literally prolapse, meaning it pushes out of the microincisions, and the pupil progressively constricts, completely blocking the surgeon's view of the cataract. And get this, up to 100% of patients on Tamsulosin exhibit some degree of IFIS. Now, your gut instinct might be, well, I'll just stop taking my prostate medication before surgery. Do not stop the medication. This is a massive myth. The drug causes semi-permanent architectural changes to the iris musculature. The risk of this floppy iris syndrome sticks around even if you stop taking the medication years ago. The secret isn't stopping the drug. The secret is absolute transparency. You literally must disclose any past or present use of alpha blockers to your ophthalmologist.
And this brilliantly illustrates how modern medicine adapts. If the surgeon is forewarned, cataract surgery remains incredibly safe. They don't just cancel the surgery, they just swap out their toolkit. The surgeon will proactively use ingenious mechanical workarounds. We're talking about deploying tiny mechanical iris retractors or specialized pupil expansion devices that look like microscopic rings to artificially hold the pupil open and stabilize that flaccid tissue. The problem is entirely manageable, but again, only if the surgeon knows it's coming.
All right, Section 3, the blood thinner question. Stop or go?
So, many older adults are on anticoagulants or antiplatelet therapies to prevent strokes or heart attacks. And historically, there was a very real fear here. Surgeons used to seriously hesitate to operate on fully anticoagulated patients, terrified they might bleed out on the table or suffer a catastrophic hemorrhage inside the eye. But today, we have to look at the modern clinical reality. The eye is functionally an isolated system. It's closed off from the rest of the body's major hemodynamics, meaning the surgical trauma is highly localized.
This concept really highlights why the modern approach is so incredibly safe. Pay attention to that term, avascular zone, because the ultrasound probe, the tool they use to break up the cataract, enters through a microscopic incision in the clear cornea. The inherent threat of bleeding is basically neutralized. The microscopic nature of the surgery makes the risk of clinically significant bleeding virtually negligible. And we have the hard data to back this up definitively. A landmark study conducted at Hartford Hospital looked at over 11,000 patients. The conclusion was crystal clear. Cataract surgery is exceptionally safe even when patients remain on their full regimen of blood thinners. In fact, patients are almost universally advised to just continue taking them. The medical consensus prioritizes your systemic cardiovascular safety, as in preventing a stroke, over the minute, negligible risk of ocular bleeding. Long story short, keep taking your blood thinners.
Finally, let's hit Section 4, overcoming physical challenges.
So, what happens when a patient's musculoskeletal or neurological limitations make a standard surgery seem, well, literally impossible? First, we have to establish the baseline physical requirement. For a standard procedure, the patient must lie completely flat, face up in a supine position, and remain perfectly motionless under a bright surgical microscope for 15 to 30 minutes. Now, if you're a patient dealing with severe osteoarthritis, rheumatoid arthritis, spinal kyphosis, which is a severe rounding of the back, or prior cervical fractures, hearing that requirement probably sounds either agonizing or anatomically impossible.
But don't worry, because surgeons have developed an immense array of environmental workarounds. For severe spinal kyphosis, they can adjust the entire surgical bed into a reverse Trendelenburg configuration, essentially tilting the whole bed down. They'll bridge the anatomical gap between the patient's curved spine and the microscope using specialized foam supports, shoulder wedges, and sometimes up to 25 pillows. Hey, whatever it takes, right? In extreme cases, if the patient still can't lie flat, the surgeon will actually tilt the heavy microscope head to operate completely off-axis, or even place a tiny traction suture directly on the eye to mechanically rotate the globe right into their line of sight. They adapt the environment to the patient, not the other way around.
But what about involuntary movement? For patients with Parkinson's disease or essential tremors, remaining perfectly still is the main danger. You might be thinking, well, why not just put them fully to sleep? But general anesthesia is heavily avoided in the geriatric demographic. Putting a senior fully under carries a really high risk of respiratory depression and prolonged cognitive delirium. It's just too dangerous. So the surgical team needs a localized physical solution to manage these macro movements while the patient is wide awake.
Now, what's really interesting here is the sheer mechanical brilliance of the solution. They call it internal surgical stabilization. First, they relax the patient with mild IV sedation and numb the eye with topical drops. Next, they establish a physical boundary on the outside by securing the patient's forehead to the bed using non-irritating paper tape. But the real magic happens in step 3. Once inside the eye, the surgeon uses 2 instruments simultaneously, the ultrasound probe and a secondary chopper tool. By applying opposing forces with these 2 tools, the surgeon effectively locks the eye's movement in perfect sync with their own hands. They literally neutralize the danger of fine tremors from the inside out.
As you've seen throughout this explainer, whether it's managing strict fasting protocols, outsmarting tricky prostate medications, navigating blood thinners, or engineering physical workarounds for tremors and arthritis, modern cataract surgery is remarkably adept at safely guiding geriatric patients through the preoperative hurdles. The surgery itself is a staggering success, but it leaves us with a provocative final question. Once the surgery is done and you are sent home the very same day, how do you navigate the postoperative recovery maze safely? What happens when your brain is receiving clear signals from one eye but cloudy signals from the other? Well, that complex healing journey is exactly what you'll need to learn about next.